meeting to order. Like last time, kind of running in right at the last moment here, but Deborah, if you wouldn't mind calling the roll.
So please acknowledge just by saying present. Senator Parker,
Here.
Representative Robertson. Are you in his place?
I'm not, Robert.
I'm not in his place. But okay. Dr. Baker. Dr. Baker. Senator Blackwell. Senator Blackwell. I think it was on Zoom. Do we have the Zoom going? I think he's here. Senator Boyd. Senator Bryan. Wendy Clements. Representative Creekmore.
Here.
Dr. Damon. Dr. Atney. Heather Garrett. Joy Hogue. Dr. Johnson. Sarah Jones. Dr. Medeiros. Representative McGee.
She's here. She just stepped out.
Okay. Kate McMillan. Representatives Scoggin. Linda Stewart. Julie Thornton. Jonathan Tritley.
Here.
John Robert Walker. Dr. Weir.
Okay, well, thank you all for,
We have a quorum.
very good. Thank you all for being here. We have some really good speakers, I think, lined up both today and tomorrow to kind of start and kind of set the stage or the beginning for what this task force is going to do. And we will get into those here in just a moment, but in your packet, you should have the meeting minutes from our first organizational meeting. If you've had a chance to look through those at the appropriate time, I'll entertain a motion to approve those minutes. A motion to approve, is there a second? Motion and second, all in favor say aye. Any opposed? Okay, so the minutes are approved. Our speakers today, and we're just going to kind of jump right into kind of the meat of things here. We're going to have Dr. Sarah Gleason, who's a Vice Chancellor of Clinical Affairs at University of Mississippi Medical Center. And then we're going to have Wendy Bailey, Executive Director of Mississippi Department of Mental Health. We're going to try to stay on time constraints as best as we can here. So we will open this up for kind of an overview and maybe some discussion by the speakers. And then I've got some possible prepared questions, as I'm sure many of you will have as well. And so let's just kind of jump right in. And Dr. Good. Okay. I think probably, Dr. Gleason, we can do this one of two ways because we've got you scheduled here for an hour. If you don't mind standing there for 1 hour, that will be fine. Or we sometimes can have you sit at the end of one of the desks here. It might be more comfortable for you, whichever is better for you. Perfect. Great. Great. And if you would, on your pedestal there, there's a small button that says push at the bottom. If you would push that, it should light up green. And so I'll let you, I don't think we've got someone here formally to introduce you. So if you wouldn't mind just giving an introduction, background about yourself, and then move into your presentation. Again, thank you for being here.
Thank you, Chairman. Thank you to all members of the task force for having me here today and guests as well. As mentioned, my name is Dr. Sarah Gleason. I am representing the University of Mississippi Medical Center today in testifying to this task force. My role at UMMC administratively is Assistant Vice Chancellor for Clinical Affairs in a broad sense. I also have clinical duties though, and I am a professor in the Department of Psychiatry and Human Behavior. I'm a board certified psychiatrist. I was educated at UMC. I did medical school there, also did my residency there. After residency, I then practiced for several years at Mississippi State Hospital, and then at the VA in Jackson, the G.B. Sonny Montgomery VA. And then I rejoined the faculty at UMMC in 2016. So again, pleasure to be here. I will also share that the last time I was standing at this podium, I was being reviewed to become a member of the Board of Mental Health. So I also serve in that capacity, and I'm looking forward to Ms. Bailey's comments later today, but I will be speaking on behalf of UMMC today in that role. All right. Click in here. You know, Anna's going to help me. We can go ahead while we're, thank you very much. All right. And I believe you all have copies of the slides in your packets. Hope that's helpful. You know, a lot of data on the slides, so we'll do our best not to bore you with that and have that for your reference, and try to get the broader assignment ahead of us. So I was asked to actually present broad brush view of mental health for our children, both at the national level and at the state level. So I'm going to try to do that. It's a very large task, of course, but I hope that this sets the stage for future speakers and other things that we consider in the task force, not just today, but as you move forward. There's a lot of work to accomplish in a tight period of time for this group. I think it's an October 1st publication date. So you know, again, happy to be part of this effort moving forward as well. So when we look at Mississippi, we're talking today about mental health, especially through the lens of our school population, kindergarten through 12, post-secondary, all right? So these are children, depending on when one starts kindergarten, maybe 5, post-secondary, maybe you're graduating from college. I know we have somebody who's heading to Yale soon. I don't know how old that person is, but you know, maybe you're 18 when you're getting out of high school, maybe when you graduate from college, you're 21. That's sort of the age group that we're talking about. Now, looking at population overall, this is not children, of course, you know, the United States population, this is 2020 census data, about 330 million. Mississippi, not quite 3 million. If we look at our school enrollment, our K-12 in Mississippi is public there, about 436,000. Then we have private, independent, other school kids, a little bit harder to get that data exact, but that's between 40 and 50,000. Then if we look post-secondary, that's going to include our public universities, our private schools, which, you know, of course, there are several in the state, private colleges and universities, and also our community and junior colleges. Again, you can see the numbers there, but all told, when we look at those numbers, we end up just with an approximation here, just to remind us of numbers, about 670,000 individuals that we are considering students in Mississippi out of our almost 3 million population. And that tells us about 23% of Mississippi's population are students at the K through 12 and post-secondary level. That's not too far off from the national average. So we're reasonably representative of the national average there, depending upon how one counts, again, post-secondary numbers and so forth. But that gives us an idea of where we're looking at. So that's about a quarter of our population, very, very important quarter of our population, the future of our state, the future of our nation. Okay, so when talking about mental health, very broad subject, as I mentioned, there's a continuum of health. What is health? Health can be perceived as wellness, developing appropriately, all the way to severe pathology. So just a little bit of discussion about this. What is children's mental health? This is some general definition from CDC. Being mentally healthy and ready during childhood includes reaching your developmental and emotional milestones, learning healthy social skills and how to cope when there are problems. Kids who are mentally healthy do well. They have a positive quality of life and they're functioning well at home, in the community, at school, and they're able to move forward. Now, mental disorders, which is part of what I do for a living, the Diagnostic and Statistical Manual, for those of you familiar with that from mental health work, it's a big Bible of disorders, and it looks at pathology. And I think we tend to focus on diagnoses and so forth, but I'll be a little bit less technical in my discussion today. I won't stick by the letter of the law of psychiatrist terminology. I'm going to be a little bit more general and use terms that I think most of us will be familiar with here in the room. So mental disorders, and I'll talk about them, they are serious changes in the way children typically learn, behave, or handle their emotions. So very general discussion there. Key thing is these differences are going to be causing the child distress and problems throughout getting through the day, getting through the school year, maybe beyond that. But mental health, as we said earlier, is not just pathology. It's not simply the absence of a mental disorder, it's also doing well, all right? So children with or without a mental health diagnosis can have varying strengths and weaknesses. I may have a child who does not meet the criteria for any mental health disorder, strictly speaking, but is going through a rough patch, or maybe temperamentally is a little bit less well-adjusted than siblings or peers. By the same token, I may have a child with diagnoses that may be lifelong, but that child, with the support of school, family, community, and healthcare community in particular, can do very well. The most commonly diagnosed mental disorders in children, again, generally speaking, attention deficit hyperactivity disorder, ADHD. I'm assuming everyone in the room has heard of that. Anxiety, again, anxiety itself is not a strict psychiatric diagnosis. It encompasses a variety of diagnoses that fall under that term. Again, I would say that most of us have some sense of what anxiety is. Behavior problems, again, very general term. This could encompass things like oppositional defiant disorder, conduct disorder, other sorts of problems that get us into significant diagnoses and challenges. There can also be, fleeting episodes, tantrum problems, other things like that. And then depression, again, a term that I think most of us have a concept of. Now, that by no means covers all potential disorders within childhood. I mentioned depression, but there's also, as we know, bipolar disorder, less common in children. Schizophrenia, yes, it can occur in children. Psychotic disorders can occur in children. However, for the purposes of our discussion here, I'm going to probably be focusing for the most part on these more common disorders or classes of disorders. Now, some of these conditions can occur together. You can have depression and anxiety together. We may have behavioral problems and mood disorders that go together. And so we have to be thinking of the whole child and of the children's needs around him and her as well. We know that depression and anxiety have increased over time. These were on the uptick even before COVID. We're seeing a lot of changes in our young people in depression and anxiety in particular. And so these are things that definitely the teacher might be the first to notice in school. It might be someone, Sunday school teacher might notice it in the church environment. So being keyed and aware of potential things that can be affecting our children in the community is also important. And as I said earlier, family, community, and healthcare factors are all related to children's health. Adverse childhood experiences, ACEs. This may be a little bit less familiar to some of you, but for anyone who's studying the literature, looking at child data, you're going to see this term. I think for me, I look at it something that, what is an adverse childhood experience? I guess something that potentially could be preventable. All right, so I was born with blue eyes. I can't change that I have blue eyes. I mean, put contacts in, that's fine, but I have blue eyes. Can't change that. But perhaps, an accident I was in, that's something that might have been preventable, or perhaps exposure to other forms of trauma, poverty, economic circumstances, even though we know that there are intergenerational challenges there, but still potentially preventable. So I've given an example here. This is from the Kids Count fact book, which is a great source for anybody studying kids and looking at health in general, but particularly mental health issues. These are a few examples of potentially adverse childhood experiences. Now, this data is looking at more, older kids, probably preteen to teen, but see some important numbers there. I want to point out. You'll see a little bit hard to read here, but those asterisks, the pink or purplish asterisks, those are areas where Mississippi, in the last fact book publication, was not doing as well as the US average. And then conversely, in other areas, we were about the same or doing better. So a few key ones here. Attempted suicide. Mississippi average there in the blue, greater than the US average. Currently smoking any tobacco product. I know that continues to be a struggle for teens across the US, but actually cannabis is something that I'm finding and seeing anecdotally more worrisome to me in my practice. Ever taken pain medication without a doctor's prescription or differently than how doctor told them to use it? We know with our opioid epidemic in particular, this is very concerning, very worrisome for our children, whether it's access accidentally to medications or intentionally. We're offered or sold illegal drug on school property. Sexual activity, and if the teens are sexually active, are they taking measures to protect against sexually transmitted diseases and pregnancy? So forth and so on. Obesity, again, that's of course we are aware that that's a significant concern for our population. So these are some examples of adverse childhood experiences, and just to make you familiar with that as you review data for the task force, terminology to be aware of. Now I'm going to take a little bit deeper dive with one diagnosis here, just as an example to show you what clinically we might do when we're diagnosing a child. Major depression, major depressive disorder. You can see, I won't read out all of the factors there, but in that pink area on your notes, or you'll see what is major depressive episode. It's a definition of a depressive episode. And when a practitioner, a clinician is reviewing a child's symptoms, he or she would go through that with the family, with the child, and see if the child met the criteria for a major depressive episode. Mississippi, under the last 2024 Kids Count fact book, did show that we were 10th in youth with one or more major depressive episodes. So possibly comprising 15% of youth in Mississippi. We were 3rd in youth with severe major depressive episodes. So depression, like a lot of disorders, is on a continuum, sometimes mild symptoms, sometimes very severe. And the impact on the child and the family system and schooling and so forth can vary depending on it. The need for clinical intervention can differ. A child with a mild depressive episode, may be able to work through that effectively with therapy and other interventions. Children with severe depressive episodes, getting into suicidality and so forth, may need hospitalization. They may meet criteria for medication and so forth. All right, so that's just an example, a little bit deeper dive with one disorder. But we could do this with all of the childhood disorders, go through them and the criteria. I don't think that we have the time for that today, but for anyone who would want more information about that, that's readily available. And I'm aware that, on the task force, you have clinically educated people who can hopefully provide that if there's more information needed. Substance use, again, big area of concern. Substance use continues to be a concern, across the nation. Mississippi, we're ranking about in the middle, 23rd in the nation in youth with a substance use disorder. Definition of substance use disorder is different from just substance use. Okay, so a young person who goes and uses marijuana for the first time, uses it once at a party, I've had enough, don't want to have anything more to do with this. That individual does not have a substance use disorder. Substance use does not equal disorder. At the same time, however, a single use, a binge episode at a party could result in very tragic circumstances. And that's the challenge when we look at substance use issues. So of course, we're wanting to help avoid the development of chronic substance use disorders. But we also see with teenagers how even not meeting criteria of use disorder, but being exposed to the substances can lead to tragedy. Suicide. Very sobering subject, very, very challenging. And suicidality is one of the things that I will see in my practice, young adults coming in, struggling with. And again, anecdotally, I would say it seems like it's more and more, but certainly the numbers bear it out as well. So in Mississippi, suicide, third leading cause of death among adolescents and young adults, ages 15 to 24. So again, that's the 2024 fact book data. And we look again, some of the other risk factors. I'm not saying currently smoking a tobacco product is necessarily associated, but you see some other examples of some risky behaviors there, alcohol, marijuana use, and so forth, but attempting suicide. How do teens attempt suicide? In the US, we know that suicidal and fatal suicide attempts, gun access to firearms is something, hanging, overdose. Those are some examples. Across the world, there are different methods that people attempt depending upon means that are accessible to them. And it's important that we as a community really think about that and talk about safety when we are with kids who are going through a tough time. Cyberbullying, again, a topic that's very much on our minds. Again, we're seeing incidents of cyberbullying, and how we define it. We're seeing it go up. It's something that makes it hits the press. It's something that is devastating schools, devastating communities. And I think I think most of us are familiar with this concept, but again, it's something that takes place over digital devices, so cells, phones, computers, tablets. Our children have access to these things at a very, very young age. It can be through text, through apps, social media, forums. It can be through gaming consoles, your gaming community, texting and messaging. And it can vary from, okay, I'm just, saying something mean, something that's not so nice. It can be posting negative, harmful things. It can involve very embarrassing pictures of nude photos and so forth. Private information, whether it's true or not, but private information that the child then realizes, oh, even if the child put it out there themselves and, oh gosh, what have I done? Perpetuating that can be it. And then some cyberbullying crosses the line into unlawful or criminal behavior. I won't go further than that on this topic, but I just do expect that we're going to see changes in this transition. And it's something I'm very curious to see how states and model laws and so forth address it, but a very important concept. Now, if I really had my way, today would be a book club hour on this book. So thanks to the recommendation of a couple of folks who are in the room, I got my hands on this book, The Anxious Generation. I believe it's Penguin Press. Jonathan Haidt is the author, 2024. So it's now a New York Times bestseller. And I think it's something that if you haven't done your own personal book clubs or you haven't talked about it in your communities yet, people will be talking about it, regardless of whether you agree with the author's perspective, whether you say, yeah, right on, I'm buying that hook, line, and sinker, even if you're a little bit more doubtful. What comes across here, though, is some very compelling data, very compelling look at the impact of online access, impact of social media, looking at changes and transitions of the way children are in the classroom. I know I have some teachers here. I know we're thinking about some various ways to maybe curtail the way the cell phone has taken over the lives of our children during the school day, at least, right? Now, I'm pulled 4 bullet points from this very engaging book. There are a number of prescriptive suggestions that Haidt comes up with, but 4 key fundamental ideas that he has. Says no smartphones before high school. That would be his recommendation to parents. No smartphones before high school. No social media before 16. So it's one thing to have the smartphone. It seems to be the social media and the TikTok, and I don't think kids do Facebook anymore, but whatever it is that kids do. I myself tend not to be so engaged in social media, but I'm also not that age group that came up with this, right? Phone-free schools. So, and we're going to see, I think we'll increasingly start seeing legislation rather in states across the continent. We're going to see red, blue states doing this. There's a lot of conversation about it. So I think it is something to be aware of. And then finally, he recommends far more unsupervised play and childhood independence. So it's very curious that in the very years that we started introducing technology, access to online communication, that our children started going to bed with a phone, keeping them up all night, we were actually more hesitant to let them ride their bike, to let them go out in the neighborhood. We were afraid to let them go to the store by themselves. So he sees this interesting contrast in the way we have encouraged children of this generation to live and grow and develop and become independent members of the community versus their time in the cyber world, which really seems much scarier if you think about it. It's a world out there, so very, very different thoughts. Anyway, food for thought. I recommend the book, reading it. It's a good read. And if anybody would ever want to get together and talk about it, I'd like to do that. Now, impact of COVID-19 on children. If you do a literature search on this topic, it's overwhelming, okay? So I just picked out a few themes, and I think this is something that we do have to be talking about and thinking about. This won't be any surprise to anyone. Social isolation, right? So kids who were in school, doing well in school, going to church, going to sports practice, what have you. That was something that we're not able to do as readily during COVID. There was disruption of routine, whether that's in any aspect of life. Routine was different. Even if it suddenly meant that dad's now sitting at the kitchen table on his laptop and in your way, and you're not, while he's connecting and telecommuting, and it's interfering with your day. Learning losses, general term there. Again, there are educators in the room. I had a very brief stint with teaching. I was taught 95 to 97 before I decided to go to medical school. I was teaching junior high, 7th grade and 9th grade. So I have some familiarity, but I think, wow, cannot imagine if when I was teaching that group of kids, that whole chunk of time had been lost. So learning losses. My spouse is a teacher at the college level, and he sees it in that age group as well. So learning losses, and how do you make up for those things, right? Is it depending upon where the child is in that progression? If it was key years developmentally, key reading years, and so on. So I think the jury is still out. It's too early really for us to see the true impact of that time away, but we expect it to be there. Economic instability, right? Economic instability occurred during COVID for many groups of individuals. Changes in workflow, jobs, and so on. Missed well child visits. Now, missed well child visits, it's very, very important, especially if we're talking about screening for developmental and other health issues, if we're talking about vaccinations and those sorts of things. So that's something that we know that occurred during COVID. So we have to think about this group of students, young people that we're talking about from a mental health perspective. This is still not completely in the rearview mirror. We're beginning to even out a little bit, but we already had some problems even prior to COVID. Again, looking at some more data here that probably easier for you to examine and digest a bit, but this comes from the State of Mental Health in America report. very comprehensive report. This shows us that in the 2023 State of Mental Health in America report, Mississippi ranked 19, okay? When we looked at youth mental health. The very complex calculation of information, how we get this score, all right? 7 factors are examined. The factors include access, say, to behavioral health in your insurance if you're a privately insured individual, major depressive episode rates, access to care during a major depressive episode, substance findings, and so forth. But through a complex algorithm, we did result with Mississippi being ranked 19, and higher is better on this number, okay? So we're in you can see us, we're kind of like not the 1 to 13, which is the lowest group, but we're that next group. And so that's interesting information and something that we'll continue to track. But again, very complex calculation. Access to care. So within that same report, we see that we were a little bit lower ranking. We were 23rd in the nation on the number of youth with a major depressive episode or major depression who did not receive any mental health treatment, so almost in the middle. The US, about 60%, Mississippi, 54%, who did not receive any mental health treatment in that setting. Workforce data from the same report. This is a challenging number to really determine. So how do we define workforce? And I say workforce, mental health workforce, that could include psychiatrists, psychologists, licensed clinical social workers. It may be other individuals with mental health specialty who are clinically available, nurse practitioners, and so forth. The United States, 350 to 1. Mississippi, according to this data, 540 to 1. But again, teasing it out is tough because if we're a small enough state, I have no friends in the community. I know people who have access to data. We call and say, hey, how many child psychiatrists are there in the state? Well, the licensed number of child psychiatrists and adolescent psychiatrists is going to be different compared to maybe who's actively practicing. It may be someone who has a license out of state and is doing some telemental health work, but not currently doing that in the state. So these numbers are notoriously tough to get at. But we are, I would say, I feel that that's representative that we are certainly have a lower access than the nation in general. So in order to give a glimpse, and again, caveat that these numbers may not really represent who's sitting at a desk or writing prescriptions or doing therapy and so forth. Licensed providers in Mississippi, if we go to the relative various state licensure boards, we would see the number of 166, I'm saying general psychiatrists. So what's general psychiatrist? I would call myself a general adult psychiatrist. So even though I do see children sort of in cross coverage, and I am trained as part of a basic psychiatry residency to have some care of children when needed. It's my colleagues that I'm lucky to have them in child and adolescent psychiatry who are the real experts when it comes to that. So I'm a generalist. Then there we have these 238 general psychiatrists, we call them, who are primary practice but out of state telemedicine. Wow, so I'm not really sure whether this is someone who has a license here and has multiple licenses, is doing some telehealth work here, or is continuing to pay dues, though not actively practicing. So it's tricky to tell there. 15 child adolescent psychiatrists, again, according to licensure board, with their primary practice in Mississippi. But I think anecdotally, we might find that that number is less if we look at full-time equivalents available and prescribing. 380 pediatricians, not including here pediatric specialists. So this would be general pediatric primary care, individuals who are seeing kids in that office setting or hospitalist setting. 219 pediatricians who are out of state, okay, primary practice out of state, 512 psychologists. Now this next number, about 2,400, we say nurses, that's going to include nurse practitioners as well. Again, a little bit challenging to call that data of which individuals licensed in nursing board who are practicing in a psychiatric nurse practitioner capacity. But we have some idea that obviously that number is higher than, much higher than the physician or psychologist number. Clinical social workers, 1,300 and some, and about 1,800 professional counselors. Now, educate our workforce. This is part of what I do as a faculty member at the University of Mississippi Medical Center. There are 28 in the UMMC's programs right now, 28, some years, one or two more or less, depending if someone gets off cycle, but about 28 adult psychiatry residents. There are spots for 4 child and adolescent psychiatry fellows, although say currently we don't have all those 4 slots filled. That is not uncommon. Across the nation, child and adolescent psychiatry spots, they go unfilled, even at the most elite places in the most cool, sophisticated spots that you'd ever want to live. And I see a certain task force member nodding his head because he knows. So it is certainly our goal, is our aim to be filled, and we're up and running doing that, and I anticipate it'll happen soon. And it's not only our goal to have those fellowship spots filled, it's to keep those graduates of those programs in the state. So that's a personal goal. 7 psychology residents at UMMC. So this residency is actually a very nationally prestigious residency as well. A lot of research based, but there's a clinical component to it. And these psychology residents are individuals who are about to finish their PhD programs. And as requirement of their work, their last year of school is a clinical/research year. So we have the wonderful pleasure of having them with us, a great source of inspiration from the academic and research side. And right now we have 4 in the child adolescent track and 3 in the adult side. 68 psychiatric mental nurse practitioner students are currently enrolled at UMMC. I was delighted and shocked to hear that number was that high when I got that number, but I think we graduated maybe about 23 last year, but we have that interest. There is an extreme interest in psychiatric mental health nurse practitioner work. Not all of these folks are ready to graduate, some of the part-time work and so forth, but one of the limits for us in able to enroll more or to expand that is these nurse practitioners are training. They do need clinical areas to do their rotations and so on. And again, if you start looking at the spots across the country, you run out of space to train people clinically. And then finally, I'd like to mention the Child Health and Development Program with, thanks to this great body, there are 8 Child Health and Development Program scholars from a variety of different disciplines. This is very essential to our early childhood work especially. In the state, I would be remiss if I did not mention the Mississippi State Hospital Psychiatry Residency Program. Very excited that this program, which is a few years old, I believe, and someone in the audience might be able to tell me, I think we're year number 4, is that right? This is our first year, full complement, right? This is very exciting. So this program it's new in the state, gives an opportunity for us to get more people in the state training, interested in psychiatry, and also from a little bit different perspective from the UMMC, which is the big kind of academic center of focus. This is Mississippi State Hospital residency there gives it a different glimpse and different approach. So it's a really good balance. So we're seeing now, about 50 residents should be coming out each year. We're hoping also too to be able to attract some of those residents perhaps to our child psychiatry fellowship. And then finally, the IHL institutions and other organizations within the state are contributing efforts with various programs for mental health related activities. All right, case scenarios, Jim, how are we doing for time? Okay, thank you. Just checking my time here. Some case scenarios. Where are the gaps? Where are the barriers? I thought about the best way to talk about this, and I think real world stories are helpful. As I mentioned, general adult psychiatry is my focus, but when I'm on call, when I'm on duty, I still see some children. Not the super young, but young adolescents and so forth. And I'm working in concert with my colleagues who are specialists in child and adolescent. I'm gonna tell you a few stories from some recent encounters. Of course, I'll change some of the details for privacy, but I think the scenarios are useful. Recently, I was on call, which means weekend, and to the emergency department presented a little first grade child. He was there with a couple of family members, with a mom and a grandma, I believe. They had driven a couple hours from another part of the state to come to UMMC to be checked out for psychiatric purposes for the child. They had used probably some of their last gas money, and we talked about that. And there was going to be some challenges probably getting back and forth and looking for care. But it turned out that this little fella, who was delightful, he's sitting there looking at his phone as the residents examining him, talking to him. He's happy as can be. Well, just earlier in the day, he had come up to mom and grandma and said, pointing to a common household implement, "I want to die. I want to kill myself." Very upsetting, shocking. Now, mom, grandma, they didn't really believe the young man wanted to do that, but this is a flag, right? Even though he's young. He had had some good encounters with his pediatrician over maybe some hyperactivity and other things, had been lost to follow up because the family had moved around, and had not had a psychiatric care per se, but certainly his pediatrician had worked with him on these things. So there had been some access to care. Long story short, child was evaluated. And we were, one of the things that came up, the family talked about already at age 6, how in his case, the screen time was influencing him. And they were wondering if he'd seen videos and things, because this language that he used didn't seem to be authentic to him. A good ending. We were able to get him set up with care closer to home, did well, did not have to be admitted to the hospital. But that's an example of a lot of resources and a challenge for a family on a weekend coming in to an emergency room, sort of, what's the right setting? What's the right way to care for our children? And that's, it's hard for society, it's hard on the family. Ultimately, what matters is that this child gets the care that he needs, probably maybe the underlying ADHD is treated, that sort of thing. A similar event on the weekend, older child, preteen, came in. This was a time where I was glad that there was texting, because apparently the young woman had texted to her friends that she was having suicidal ideation. And this was more severe, more serious. And the young woman talked about an adverse childhood event that had occurred. There were allegations of a sexual assault. This was discussed. Family, really good communication, luckily, between the mom and the child. And in that case, we were able to say maybe a higher level of care is needed. All right. So again, not one size fits all, but these are the sorts of things that we see. Similar scenario, age 16, young person came in, but this time struggling with some substance use issues, and had taken an overdose, had gone ahead with, it wasn't suicidal ideation, it was actually a suicide attempt. And the suicide attempt, fortunately, was able to be managed medically, but the nature of the overdose was such that it did absolutely require medical hospitalization, treatment by toxicology. This individual will do well, and now the individual is able to be moved to an area where she can get behavioral health interventions. That child, though, had never had any psychiatric indicators prior. There were some social circumstances that were very challenging. The family had some engagement with custody issues and so forth. And the custodial parent said, we tried to get in. We had an appointment at our local mental health center. We had this. It was set up. We just couldn't convince our child to go. So that's another variation. If we look at barriers, so that's a scenario where how do you get a 16-year-old who's having some hard times to, lead a horse to water, can't make it drink kind of thing. The resources were there, the family was in tune, but the child didn't want to engage. And they're, these are teenagers, right? We have other scenarios of right size, right fit. Maybe we're overusing certain resources and underutilizing others. And these are the things that I see as the gaps and barriers, generally speaking. And then system of care. I mentioned, court engagement. I mentioned in one case. I mentioned, pediatrician involved in one case. other scenarios like this, how do we as professionals, family members, educators, lawmakers, how do we get together and make the most of what we have? I know we're lean on some resources. I mean, that's true across the nation. But we have some special opportunities here. I think this task force can bring that to bear. UMMC is addressing the gaps, and I'm proud to say mental and behavioral health for Mississippi's kids. And I want to take us through just a few of the programs that we are actively engaged in, and to remind those of you who may not be familiar with them. Inpatient services, okay, so we have a pediatric psychiatric inpatient unit. That's a 12-bed unit, it's an acute unit. We admit children ages 4 through 12. The key thing there is it's meant to be an acute unit, not a long-term stay. So this should be short stays, ideally getting kids to less restrictive environments, moving them on to intensive outpatient programming, other sorts of things, getting them back in school as soon as they can. Of course, while they're there, they're getting school, they're getting education, they're getting therapies. So their education is not ignored while they're there, but we want them back in school. We want them back in their home environment. Sometimes the battle, even if a child has, gotten all they need out of the acute stay, maybe medication was adjusted, maybe we determined they didn't need medication, maybe we got them off of medication. We got some psychological testing, we have a better sense of where they are on the educational spectrum. Sometimes though, placement then is the hard issue. And then an acute unit, which was never intended to have a child there longer than a few days, becomes months. And there have been some cases like that for a variety of reasons where placement is particularly challenging. A lot of children who've been through trauma, who have family challenges, economic challenges, placement challenges. But that's our pediatric inpatient unit. We're very excited that hopefully target completion date by late 2025, we'll have an adolescent unit. That has been a gap in UMMC's ability to treat kids who do not have acute care needs. So we've had this 4 through 12, and then 13 to 17, I cannot admit if I do have the child who's a post-suicide attempt, the teen who does need to have acute care. 18 and up, I can admit, but I have this 13 through 17 gap at UMMC, and we're very excited that again, thank you for legislative funding has been a big part of that. Lots of efforts for a long time on a lot of folks, but very excited to see that come to fruition. We have there are in the state other partners that we work with, other hospitals where we do transfer kids in that teen group, excuse me, who need the care. And we're grateful for those partnerships, but this will be an opportunity to have that on the UMC campus. Multidisciplinary, so forth and so on. Outpatient services, the Center for the Advancement of Youth Clinic. This is the main hubs located in Jackson, not too far from Meadowbrook, I guess exit 99, Meadowbrook Road area. Statewide, it's a statewide clinic though. We reach out, telehealth, we reach out in other ways. There are some satellite programs across the state. And this is a comprehensive coordinated care clinic, a cooperation, a joint venture between pediatrics, developmental pediatricians, and child and adolescent psychiatrists and psychologists. Wonderful program. Again, multidisciplinary care, research, state-of-the-art opportunities, evidence-based opportunities. And ADHD, autism, we get a lot of referrals for those sorts of needs, learning problems, and so forth. River Chase Clinic is located in Flowood. That's where when I was outpatient, I would primarily be. That's a general psychiatry clinic, also addiction clinic. That's for adults, so 18 and above. But again, since we're talking about young people here who still fall in that transitional age youth group, they could come to River Chase for care. And we do have an addiction specialist there. And then the Center for Integrative Health, which is multidisciplinary as well, for children and adults with chronic medical conditions. We look at lifestyle opportunities for them, ways to help people who are struggling with maybe their diabetes is contributing to mental health issues and so forth. And that team can work with the patients and their families and so forth. That clinic is located in, excuse me, Ridgeland. Mississippi Thrive is a federally funded grant through HRSA that it seeks to improve early childhood developmental health outcomes. Now, I know we're talking K through 12, But remember, you can't get to K and be ready for K if you didn't have good prenatal care, if you didn't have the childhood opportunities up until kindergarten. And this is some of the work that Thrive does. It's working to improve and build statewide developmental behavior health system again. So I think there are a lot of lessons to learn from some of the successes of the developmental work that's been done. Trying to increase our workforce, getting pediatric medical homes and so on. This is a compelling slide, I think, borrowed from our Mississippi Thrive folks. Even today, only 1 in 3 young children receive the appropriate developmental screenings. About half of the estimated well-child visits that should happen don't occur. Only 2 in 5 are ready for school. So we want all of our children to be ready, because when we get to kindergarten, we want to make the most of it. Now, Thrive has done a great job. Several years back, I think we're looking at early 2016-ish, we had the lowest ranking. We were 50th in the nation. Now we've moved forward to 34th in the nation in terms of our screening and other things that developmental screening that has occurred. So this is how, with concerted effort, the funding that really adds up to something. And I think there's some lessons that we can take for the older group. BHIP, again, talking about little kids, but until we get the little ones ready, they're not going to become healthy big kids. Also, this is through SAMHSA, provides early identification and treatment of mental health needs for infants and preschool age kids, especially those with clear risk factors in the NICU, histories of prematurity and so forth, and clinical and community services, a lot of screening. And this is something I can share with this group, as I shared before. I happen to be, as a family member, also a consumer of care in the state of Mississippi. I have 2 children. I have a 27-year-old, typically developing young woman, and then I have a 25, almost 26-year-old man who has autism. And he was born and raised in Mississippi, and we've had some very good successes. He's been very lucky, doing well, working at the Flowood YMCA part-time. He is disabled. He is on SSI, soon maybe to get SSDI, because he's put time in working. So we're very excited about that. But I look back and I think, wow, if in 1998, 99, we had this program, I wonder even how many more gains my son would have made. We had access to care. We did not have, we were not out of luck in those ways, but this is very, very exciting. It's things that there were some risk factors that probably I think this program might have helped us identify earlier. School-based telehealth, we're doing a lot of work there. Again, this is an ESSER grant from the MDE, Department of Education, to provide telehealth services to K through 12 across the state. And again, looking at our transportation needs, the challenges that we have with families having enough gas money to get, or time to get to a clinic. This is key. And this is something I think this task force, I'm sure, will have its eyes on, models for getting care to kids in schools or in where the kids are, rather than kids having to go to clinics. So whenever that's appropriate. A lot of total number of telebehavioral health visits in the 2023-24 school year was 574, and 74 participating school districts, 421 schools. So this is an exciting stat on this. So Mississippi school-based telehealth from the 22 to 23 year to the following year, 23-24 fiscal year, appointment volume up 429%. So, 4.25 times more the number of behavioral health visits as the prior year. So this is catching on. And their top diagnoses: anxiety, depression, ADHD, disruptive mood dysregulation disorder, a little bit a different term, and the adjustment disorder, but some of the sorts of the classes of disorders that we mentioned early on. CHAMP, exciting program. And there are 3 versions of CHAMP, but Child Access to Mental Health and Psychiatry. Some of you in the room are familiar with this. Federal grant, again, to HHS, HRSA. This is a free statewide consultation service, both by phone and telehealth, that allows primary care providers to contact experts. So the pediatrician in the clinic, general pediatrician in the clinic, who says, you know what, I'm here in whatever county, I really think my kid doesn't have access to, this patient can't get to specific behavioral health treatment. but I would feel very comfortable treating this child's ADHD, or yeah, I want to feel more confident handling this case of depression. That provider can call the expert. So it's provider to provider care, and it just exponentially expands access to expertise. Again, we don't have child and adolescent psychiatrists. There, as my former chair, Dr. Scott Rogers used to say, rare as hen's teeth. And they still are, but we can expand, we can echo another program, we can get that word out. So CHAMP is championing that. It's been exciting, and you can see the numbers there about progress. But there's also CHAMP for schools. So CHAMP, again, trying to get that word out so that providers can talk to teachers and educate our educators. So the first program is, you know, a medical professional or clinical professional talking to another clinical professional. Here, this is education and consultation service for teachers and school staff. There's also a CHAMP for moms, which is also, you know, looking at moms who have perinatal mood issues, and we know how important that is developmentally. If mom's not well, a child is going to have problems too. Teach, again, ESSER grant from the federal, so from MDE, and our goal here is to improve behavioral health of Mississippi students by, you know, increasing capacity and confidence of our educators, our teachers, our administrators, to help deal with common behavioral problems in the classroom. I imagine it must be very frightening to be a teacher and you see that somebody has texted or handed a note, I'm having suicidal thoughts. That a lot of times ends up with teacher not knowing what to do, obviously raising flags, getting help. The child then has a long day or evening spent in the emergency room. Didn't always need to have emergency room care, but the teacher, you know, needs some in-between asset there to help figure out what's going on. And there are going to be some educational opportunities here. Finally, as we get to our older kids, you know, we've gone from, you know, in utero now looking at the older kids. A couple years ago, through the University of Mississippi Medical Center, some of our psychology group went ahead and, with GEAR funds, went ahead and did a study of availability in our colleges and universities, what's available for mental health access. Survey data here is summarized. Some of you may have been at presentations where that was summarized. But the key thing is we've got kids, young people in distress, and we learned that our mental health services were frankly overwhelmed. I mean, the mental health services in our institutions of higher learning did not have the capacity for this, increasing anxiety, depression, substance use disorders, other things we're coping with. And conclusion was additional telehealth resources were needed. And I'm excited to say that the Unite Telehealth Clinic has just opened its practice on April 15th of this year. Again, through a federal grant, this program, Unite Telehealth Clinic, they're based through some UMMC providers, but is partnering with university counseling centers across the state with getting kids, young people, they're not kids anymore, but getting young people the care that they need. And it's nascent. We're anticipating, I think 5 out of 8 schools so far have participated. That was, you know, April 15th, you're at the end of the first semester. Very excited to see going into the fall semester, where we'll have some uptick and be able to work on that. So I think that's all I have. Thank you.
Well, thank you. I think the goal with having you go first was to allow you to bring kind of data to the table. I think that, and if you don't mind, we'll just have you stay there because the question and answer time, I don't think is going to take up an extreme amount of time. But the data here, and I'm going to ask Pierre to make your PowerPoint available to everybody on this committee, because I know in the print and on the screen, some of the data was a little harder to kind of follow along. I was able to pull it up on my iPad, and it was easier to kind of get into the numbers and see the data there. So we will make that be the case. There were a couple of things that I wanted to ask about, and then I'm going to open this up to the entire committee here. And first of all, I want to thank Representative Creekmore for sitting in for my co-chair, Rob Robertson, today. You know, and so he'll be first on the question list here in just a moment. But there were a couple of things that I just wanted to get your input on, because this came to me from several people leading up to this, and that had to do with bullying and the impact that that is having on kids, you know, whether that be in-person bullying like it was maybe when I was in school, or the virtual bullying. And I didn't see anything really in the presentation that addressed that, but could you give us your kind of input on that?
Sure. I think my concern from the cyberbullying standpoint is ease of access. And as you said, when we used to be kids. So when I was a kid, if somebody was mean to me, it might be something the teacher noticed, handled in the classroom. My big brother might go and beat him up when we were walking home from school. No joke. One time he took snowballs and threw them from the car at at the kid who had been mean to me. So
That was in Elf, wasn't it?
pardon?
In the movie Elf?
So yeah, this is pre-Elf. I think they
Okay.
took it from my brother. So the notion of, you know, things being contained. So if I was bullied, if there was a note, if there was a mean thing, if a mean girl thing happened, it didn't go viral. All right. So the power of internet, power of social media to make things go viral, they never go away. All right. So even if, you know, this presentation today, it's never going away, right? Even if we try to unpost it, if I've made an error or something, it's forever. 30 years ago, maybe it would have VHS recording, who knows? But the permanence, potential permanence of online access. Now, that doesn't mean that in-person bullying isn't as scary, you know, and can be as destructive to a child as well. But I think that's one of the biggest concerns that I have. And point well taken. I didn't have a lot of data there for you, or any data, truly, just trend and concern there. But if there is a desire from this task force to have more information, you know, we can certainly work on that and submit some more data from UMMC. And I'd be happy to have us do that.
And I certainly think that ties into your comments from the Anxious Generation book. I think that was something that was kind of key in there. And I appreciate you bringing that book up as well. And just a couple more just kind of specific background kind of questions here, but are you seeing or are you hearing in your field any best practices or any ideas around the country that you see or hear that are working elsewhere that you think we should try to mimic in the state of Mississippi?
I think we have to watch out about a scattershot approach. Okay, so I think there could be a temptation of, let's try everything. We want to have options, but I think there could be a risk of diffusing the power that we have. So focusing on key issues and getting some things right and building on them. Now, again, whether I can back that up with other experts, I don't know, but that would be my observation and concern, that we focus on some things and do them well. So like I gave the example of some of the things that early developmental has done, Thrive. There are some programs that I would say, let's try to see what they've done. What have they successfully done to bring in the community? If we do this, if it's just teachers only, if it's physicians only, if it's psychologists only, we'll fail. It has to be a concerted effort, but we have to focus our effort. Okay? I think access to the telemental health is very important, but again, that can be a double-edged sword, and we have to know which kids are the right size for that. So if we are assuming that, you know, every kid one size fits all is going to be in there, problems to be solved, that's also a risk factor. So I'm kind of saying two things at once. I'm saying we need a variety of services, we need a continuum of services, but we need to see what's evidence-based, what works, and build on some successes. And, you know, interagency work, building on those sorts of things. We have so many resources that, you know, I'm embarrassed to say, here I am, a board member of the Department of Mental Health. I'm a psychiatrist in the Department of Psychiatry and Human Behavior at UMMC. I will have families call me, hey, Dr. Gleason, my neighbor's having this problem, eating disorder, say, for example. I don't know where to tell them. I don't have the book, the guidebook. I want the yellow pages. I want to know exactly where the resources are that exist so I can get kids the help that they need as quickly as they need it. So watching out for duplication of effort and then also coordinating our efforts. And I truly think it's going to be, you know, all hands on deck It's going to be state resources. It's going to be private resources used to the best benefit and so forth.
Okay, thank you. I'm gonna turn over to Representative Creekmore here. I know he has a great interest in this, and I know he'll have some very good questions, so.
You put me on the spot. Dr. Gleason, thank you. How long does it take the mind to develop from adolescence to adulthood?
25, I think, is you're fully myelinated. Like I was thinking about that. I have this 25-year-old and 27, and I'm thinking, oh gosh, I mean, I hope it gets better after that. No, I think it's all downhill from here. And I will say that I am not the best person to give you the neurobiology of it, because it's not my micro expertise. But we do know that there are key periods of development, right? So that 0 to 5, and then we slow down. Then we have these periods of adolescence where there's this intense burst of development. So, you know, it's not an even development, if that makes sense.
And I've read the book, and in the book, it makes the developing of the mind has been changed by the screen and the screen time. Do you agree with that? And is that contributing to mental health and children hurting themselves?
I am very interested in the book. I want to see how the data bears out. I think there are issues of correlation versus causation that I'm excited to see neurobiologists really play out. There are some areas that we would like to see some, you know, randomized controlled studies on to, hey, is this working or not? But what's exciting though, is that the author is open to that. Hey, you can point out the errors I've made, challenge the data. So I think it's a living, breathing document, as opposed to, okay, I've written this book and I'm moving on to my next one after I get my, you know, Pulitzer or whatever. So that's the exciting thing about it. But the topics that will be spurred in the research, I think that will be spurred, will be exciting. I mean, even the idea of, okay, no phones in schools. There are interesting ways you could set up experiments, right? You could say, if we have 4 cooperating schools, school A, you just business as usual. Don't change a thing. You keep doing what you're doing. Don't change it. School B, okay, no school, no phones at all in school. See how that works. School C, you know, some variation of that. Maybe no phones, but also we're going to have the kids do certain activities to help them gain independence, right? So there are some population level experiments that could be done.
And do you see more mental health issues with children that grow up in a single parent family?
And again, I feel like I'm out of my depth to answer that question. So I think it would be unfair. I think it's probably generally safe to say that stability in a household, and that's for adults as well, stability, you know, not having to worry about where your next meal is coming from, not having a violence in the home, having the things that make you feel safe and secure, would be my guess. But again, I will defer to, I know I have more experts on the task force who can back that up with data, but that would be my sense.
Thank you.
Senator Boyd?
Thank you. I think we're all in the process of reading or rereading that book right now. I've got a couple of questions in regards to, I'm going to narrow this down. I've got a lot of questions, but I'm going to narrow just a couple of questions down to CHAMP because I'm very excited about what y'all are doing in this arena. Right now, it's just available in regions 6 and 12 mental health regions, correct?
I believe that's correct. I'm going to go back a slide.
I think that's what you're indicating. Is there a plan to roll this out statewide, working with the other community mental health centers?
It's definitely something that could be explored. Of course, funding, and may I defer to my lifeline here? Yeah, it's funding.
Okay. Okay. And within CHAMP, I saw a couple of states present some of what they're doing in mental health, and we are all doing this at the same time. Many states are. So we are all having these same discussions. But in one of the states, they presented that they did train the trainer programs for school districts in regards to mental health. Is that part of a service y'all already have, or is that something maybe you're looking towards right now?
Again, so I don't misspeak, since I'm not actively engage in the program. It's, in my department, and I certainly know Dr. Philip Meredith and Dustin Sarver and others who are active in it. I can certainly get you that information.
Okay, that would be great. And then my next component of that is interesting. When I saw the states speak last week, a number of them, they didn't have a parent component, which to me, that is something that we very much need to do in this state. So when you get that information, could you find out if we have a parent training component? Because I know there are many parents that call me that would like to have some training themselves on what to look for and what to seek.
That's great. And that also makes me think if we've got homeschooling population, which is the population that, we did not address directly, but or, just parents in the regular school setting. I mentioned the Champ for Moms, which is watching out for moms in that perinatal postpartum setting, but, how about families? And again, the full spectrum continuum of care. Great questions.
Okay, all right, I'm gonna stop at those.
Yes.
Hey, sorry. In line with that, so the school-based telehealth has been separate than CHAMP, right?
Yes.
Okay.
Mhm.
Do you know how long the funding, because I know that it had an increase in percentage, but that first year there was very few people who accessed it, and the behavioral health was even harder to get. But it was able to be expanded and recommended. Do you know funding wise how long that's funded?
So this is something I think it's good for this audience to
Yes,
hear,
no,
right?
I'm
So
good.
we're at the end of our federal year, right? September 30, right? So September 30,
So
grant
this
funding.
year, we're kind of concerned
Right.
that we'll lose access to that.
And so, it would be wonderful and delightful to be able to continue this sort of service. Yeah. Yeah, yes, right. So as Ms. Sparks is telling me, telemental health is a component of sort of the telehealth K through 12, which also had, primary care and other things. In particular, the mental behavioral health component is one that we are actively seeking some forward funding so that we don't lose momentum and can continue with that.
And I just wanted to highlight that because I was
Yes.
fairly sure that was the case. The second part of that, to build on the question I think Senator Parker was asking in regards to looking at some of the things that have been done in other states. And you, in your initial presentation, did indicate that there had been some states that had made some moves related to fading student access to cell phones and social media during the school day. I know Marshall County, one of our school districts, is attempting that this year. In looking at those programmings, what you're saying is you just want to see the evidence in that, or is that something you would recommend the legislative body to kind of look at those examples in other states?
And we have some information on that can be shared too. We've done a little bit of research of other states. I don't have all that right in front of me. Interesting. We tend to states by states. We could say, hey, let somebody else do it first, and let's see if that works for them. One approach, but it seems to be something that's kind of a rising tide, or depending on how you look at it. So, hard to know. In terms of, there's also community efforts on that too. So, legislatively, if there isn't that will, there may be, I would be very curious to see if there are parental movements, but.
And I think that's why, like I said, the individual school district has made that choice.
Right.
Probably because the community is supportive of that at this time.
So, and you probably will see different approaches, right? So again, New York, for example, the boroughs wanting to do one group of thing, well, will the governor at another level approach it? So I imagine, depending upon different political climate, we'll see different things, but it would be nice to see that data.
Thank you.
That's really good, Dr. Johnson, on that. I guess the follow-up to that would be, if we did have a pilot program, for example, in Marshall County, like what's being described here, what would be the metric you would try to measure out of that? I think that would be,
Right.
it'd be a little harder one, because I don't know that it translates into reading comprehension. It would probably have to be a teacher kind of response type of scenario. Would you
it-
agree?
I think there are various things like even behavioral changes, okay, fewer visits to the principal's office for behavioral disruption, less absenteeism. There may be, I think in the book, or there are some recommendations about that, but that would be where you'd get, your masterminds, knowing development, trying to see what could we see as an outcome measure. But change is hard. I was thinking, I told you about my brief stint as a teacher in the 90s. I had just arrived in Mississippi. I have 30 years in Mississippi this month. Just arrived in Mississippi, took a teaching job. And that was the year that the driver's license age changed from 15 to 16. And it was as though, oh, we can never make this happen. I saw those 15-year-olds, they were looking for every hardship exemption they could figure out. But somehow the change was made. So, these are challenging things. It's families, some families saying they feel more secure, right? Where they want to have their child have the phone. They don't feel safe in the school. So a lot of that is going to be the community getting around it and behind it, if it's something that is worth pursuing for them.
Very good. Other questions from the committee? I know we're right up on our time to change speakers here, so I really appreciate the
Thank you very much for
the
having me.
background information. I think you've done a good job of
Thank
what
you.
we were hoping you to do, and so we'll
And-
have
And again,
additional follow-up questions will be
Absolutely.
via email or phone call.
absolutely, and we have time and we'll work to submit the answers in writing. Thank you so much.
So our next speaker, we gave a small gap here if anyone needed to take a quick break, but if no one needs to take a break, we can just kind of roll right into the next speaker. We have Wendy Bailey, Executive Director from Mississippi Department of Mental Health. And if you briefly need to step out and go to the restroom or anything, feel free to do that at this time, but we'll just kind of keep rolling. And Ms. Bailey, if you wouldn't mind, just like before, just give us a little background on you. And, a lot of us know that background already, but share with everybody here, everybody watching, and then you can give us some information on what you think you can do to help the knowledge of what we're looking into.
And the presentation, the PowerPoint's been shared with Peer2, so you all can have that available electronically. I don't have quite as many data points, so it might be a little bit easier to read, I hope. That was excellent data that was shared. My name is Wendy Bailey, and I'm the Executive Director for the Department of Mental Health. I've been with the agency, January will be 20 years. And I've been in this role for 3.5. So I'm glad to be here today to talk to you about, I was asked to talk specifically about services that are available in the state, and then some areas and some gaps. I will start off by saying probably 85 to 90% of what I'm going to talk about, the Department of Mental Health does not directly provide the service. We certify providers to provide these services. So let's. To point. The green. There we go. Okay. So the first thing I was asked to talk about is just a system overview, and I'm going to do this very briefly, but the state's mental health system is made up of 3 components. The first is state-operated programs and community service programs. Those are one that the Department of Mental Health directly operates. In the area of children and youth, we have 22 beds at Mississippi State Hospital at Oak Circle Center. I'll talk a little bit more about that in a moment. And then the specialized treatment facility on the coast, which is a PRTF. Then you have regional community mental health centers. There are 11 regional community mental health centers across the state, and they are part of county government. There's a commission that provides that oversight. And then we provide certification and monitoring and funding to the community mental health centers. And then other nonprofit and for-profit service agencies and organizations. Right now, we have about 125 DMH certified providers across the state. So the state operated ones, you have Mississippi State Hospital. Most of you probably know that's located in Rankin County. Fortunately, still called Whitfield by a lot of people, but it's Mississippi State Hospital. They have a child and adolescent unit, and they provide mental health and substance use treatment. And then we have the specialized treatment facility in Gulfport, which is a PRTF, as I mentioned, a psychiatric residential treatment facility. It's for adolescents 12 and up, and they are in need of longer term care. I will echo something that Dr. Gleason said. Mississippi State Hospitals is an acute unit. Short-term stays is what is the purpose of that. Specialized treatment facility can be longer-term stays. They're supposed to be only up, though, to 6 months. We are seeing more and more cases because there's issues with placement that people are staying longer. So that means beds are not turning over as quick either. And we're seeing that both at Mississippi State Hospital and STF. At Mississippi State Hospital, again, they have 22 beds. They served 131 people in FY23. STF currently has 32 active beds. They have capacity for 48, but because of staffing challenges, there's only 32 beds staffed. It's extremely difficult to staff on the Mississippi Gulf Coast and everywhere in Mississippi. And they, in 23 though, which is where we have the data for right now, they had 26 active beds. They served 76. So we've added 6 more beds since. The Regional Community Mental Health Centers. So as I mentioned, they have a range of community-based services, and the Department of Mental Health is responsible for certifying, monitoring, and assisting the community mental health centers. There are core services that if you are certified as a community mental health center or a private provider that's certified, have to provide in the state. And we'll talk about those that are related to children and youth. So there are currently 11 community mental health centers and 33 DMH certified providers that provide children and youth mental health services. Earlier I said there's 125, but 33 of those provide services to children and youth. These are the required services. So if you're certified to provide children and youth services through the Department of Mental Health, these are the services that are required to be provided. Outpatient therapy, community support services, psychiatric physician services, crisis response, pre-evaluation screening, peer support services, and day treatment. So I'm going to talk about a few of these. School-based services. The community mental health centers are required to offer services to the school. That's part of the DMH operational standards. However, the schools do not have to accept those services, but they are required to ask. If a school says, no, I do not want to get my school-based services from the community mental health center, the community mental health center documents that and places it in their file for when we go out and do site visits, we can see that they made the offer, but it wasn't accepted. There are some schools that contract with a different provider for their services. So you can see here, there are 519 school-based therapists that are at schools across the state, and there's a variety of services that are provided. This one's a little more difficult to see, but you've got screeners for substance use. Region 2 provides that service. You have A&D prevention that's provided by Region 8, and a variety of different services. I will say this. We have received feedback, particularly from the Community Mental Health Center, about some barriers to school-based treatment. Sometimes that is a location, because the school needs a place in the school for the therapist to provide those services, and they need privacy, and they need internet access and telephone access, and so that's not always easy for a school to set up. So that's one of the barriers that we see. Another barrier is a lot of times behavior and mental health issues occur during the school day, and maybe they're not that receptive to the student leaving class to go receive that therapy or that intervention. And then staff shortages. You're going to hear me say this over and over. And I love Dr. Gleason's slides on workforce shortages, because let me just go ahead and say, whatever recommendations you make, if there's not a workforce to implement them, it's not going to work. And there is a behavioral health workforce shortage in the state of Mississippi, across the nation. But again, what were we, 48th in the workforce, 45th, 48th with workforce shortages. School-based services, day treatment programs. These are available in schools and at centers, both with the community mental health centers and private providers. There are 120 school-based programs and 129 center-based programs in the state. There's 8 community mental health centers that are providing day treatment programs and 16 private providers. There's requirements in our operational standards on how you have to, minimum standards of how day treatment has to be provided. For example, they must operate at least 2 hours per day or 2 days per week. So you have to receive at least 4 hours worth of day treatment services if you're enrolled in the program. Navigate. You asked earlier with Dr. Gleason about evidence-based practices and evidence-based programs that show promising work. Navigate is one. Mississippi was one of the first states that took advantage of block grant funding from the federal government to start first episode psychosis programming. So what this is it's an evidence-based program for youth who are between 15 and 30 and have experienced their first episode of psychosis. So you have intensive case management, group therapy, family education, employment services wrapped around that child at an intense level because they have experienced that first episode of psychosis. You can see here a quote from one of the participants. And I'm going to just kind of go to the second part of the quote, but he stated that in just 7 months and being involved with Navigate, he had seen more progress with his mental health than he had seen in his entire life. It's a very intense program, but again, it's designed that way because it is for somebody who is experiencing that first episode. This is something right now that there's 8 providers and it's being funded through federal government dollars, but we do not have it statewide. So you can't see that side right there. Okay, so these are Navigate numbers served. FY16 was the very first program in the state. It was only started half a year. It was a pilot. You can see that was when it first began with 4. The numbers are steadily going up. We've also added more Navigate programs as well. But this circle here, 95% of the people that were served in Navigate were able to remain in their homes and in their communities. And in the beginning of Dr. Gleason's presentation, she said, what do we want for the children and youth in our state? To be maintained in their homes and communities. We do not want to serve them at Mississippi State Hospital and STF as a last resort. We want them maintained in their homes and their communities. And Navigate's doing that. Intensive community support services. This is something that's just recently been added as an array to the services. If a child is being discharged from inpatient care and they're returning to their home or communities, and inpatient care could also be even an emergency room visit, but if they've had to have some type of inpatient intensive care, ICSS has a low client to staff ratio, and they can provide community support services multiple times a week. They're not limited to only 2 visits. They can provide multiple visits. So right now we have 35 ICSS positions. All the community mental health centers have at least one. Several, of course, have multiple. In FY23, there were 154 served. And in the first half of FY24, we already had 104 served. So we're seeing that number increase as well. Again, those are services that are provided in the community rather than an office setting too. They can go to their homes. Wraparound facilitation. This is a family and youth guided care coordination process, and you have some excellent experts on wraparound facilitation on this board or on this task force. It is care coordination and a planning process. There are currently 11 providers that are certified by DMH to provide wraparound facilitation, and it's a partnership. It's not Department of Mental Health. This is a partnership that we're involved in, but the Division of Medicaid and the University of Southern Mississippi is who implements and helps us sustain that wraparound facilitation. You can see the numbers here. Now, I will tell you they've decreased, and there's a couple reasons behind that, and we want the wraparound numbers to go back up. It's something that more children absolutely need to have. They've decreased for a couple of reasons. One, we have a few fewer providers now. We were up to like 14, 15 wraparound providers, and we now have 11. Also on that is staffing issues as well, and some other factors at play, but we really want to focus in 2025 to help improve wraparound facilitation with all of the partners that are involved. Making a plan teams, MAP teams. This is in legislation. It's in Mississippi Code. And MAP teams are local multidisciplinary teams that meet monthly. And they review cases for children and youth from 0 to 21 years of age. The important factor in this is it's a team. And it's not just a team of mental health professionals. And that's what's key here. It's that holistic approach that Dr. Gleason was talking about. It's not just the mental health aspect. There are 55 MAP teams across the state, and they serve 764 children and youth in FY23. You can see some of the local partners, CPS, youth court, hospitals, school districts. There's many partners that play in a MAP team. Hinds County has an excellent MAP team. Juvenile outreach programs. So juvenile outreach programs, there are 12 across the state, and they're operated by the community mental health centers. And these are designed specifically for individuals who's been involved in the juvenile justice system. And the purpose is, as they are leaving the juvenile justice system, to wrap services around that individual. You can see the goal is to prevent future impact or future connections with the youth court. The programs provide assessments, community support services, crisis intervention, therapy, and wraparound facilitation. You can see here that there were 1,660 youth served in the first half of FY24. We have FY24 and first half of FY24 and some FY23 data too. So you can see in this chart here, in the first half of FY24, there were 1,164 youth, or 70% of those served were referred to their local community mental health center and were continued treatment after leaving the juvenile justice system. 15% of those became re-involved. 15% is too high, but still 15% or 75% did not become involved again with the juvenile justice system after receiving services through the juvenile outreach program. Adolescent offender programs, this is something Mississippi legislature funded with ARPA dollars. They're just now starting to get up and going, so we don't have a lot of data on it yet. But 30 people in the mid-year of FY24 had been referred to these programs. Again, it's a day treatment model. It's evidence-based, and it is a team treatment-oriented approach to try to address the mental health needs of adolescents who have committed offenses. Supported Employment Policy Academy. So Mississippi was one of 7 states that were selected to be a part of this. The other states were Alaska, Illinois, Ohio, Oklahoma, South Carolina, and Utah. And this gave an opportunity for a team to go to Washington, to SAMHSA's headquarters, or Virginia, and to spend some time working with the other states and working together to create a plan for supported employment for transition age youth. So this is youth ages 16 to 24. Again, it's that holistic approach. It's not just mental health treatment, it's housing, it is employment. So we want to make sure that these children are being able to be connected to supported employment. It focuses particularly on kids that are transitioning out of foster care or transitioning from juvenile detention facilities. It's a 12-month program that we're working with several different agencies. NAMI, CPS, DHS is all involved in this. 988, this is not children and youth specific, but I want to mention this. So 988 is a 3-digit behavioral health crisis line. It was passed by Congress in 2020, July 1st of 2022. The National Suicide Prevention Crisis Line, which was a long 1-800 number, changed to 988. This is available 24 hours a day, 7 days a week. In Mississippi, there's 2 crisis call centers. And just this past fiscal year, there were over 13,000 calls in Mississippi to 988. One thing that I think Mississippi should be proud of is we have one of the highest in-state answer rates in the nation. We're consistently 96, 97, 98% in-state answer rate, which means if you're a mom and you call 988 because you're having concerns with your child, you're going to be connected to a trained counselor here in the state of Mississippi 96, 97, 98% of the time. And why is that important? They know the resources. You're not rolling to a call center in Georgia. So we're very proud of the efforts with 988. It's still infant and it's growing. One of the things coming up is more training for 988 Lifeline crisis counselors in the area of children and youth and how to respond to children and youth. This is something that I wanted to make you all aware of. The Department of Mental Health has worked with the Department of Education to create a toolkit around 988 and specifically suicide prevention. And everybody's kind of working on it. We got a draft right now and we want to get it out to all of the schools before the schools start back in August. And what this toolkit has in it is it provides information about warning signs and risk factors. You mentioned bullying. It specifically discussed bullying in this report. It talks about programs and trainings that are available like QPR, that's Question, Persuade, and Refer. Youth Mental Health First Aid, Open Up Mississippi, Shatter the Silence. It will provide information about 988, mobile crisis response teams, just basically resource sharing for everyone who works in the Department of Education. It also talks about postvention, after a suicide, how the school can respond. It provides a lot of resources, some national, like the American Foundation for Suicide Prevention, and some excellent ones in Mississippi, like Mississippi State University's Alliance Project. And it also includes the Mississippi Department of Education's model policies for suicide prevention. Some of you may recall in 2019, the Mississippi legislature passed legislation that all schools have to have a bullying policy. They have to have a form on their website to be able to report bullying, and they have to have suicide prevention training. So we kind of recapped some of that in here as well. A few of the trainings that are offered to schools I wanted to highlight. This first one here is mental health first aid. So the Department of Mental Health has a grant to provide mental health first aid at no cost. There's multiple other providers and community organizations throughout the state that's offering mental health first aid as well. If you want a mental health first aid training, I promise you, you can get it. So you can see here that last fiscal year, there were 45 trainings that were conducted. Mental health first aid is the best practice. Because of that, you also have limited classes. You can have between 25, max 30 in a class. It is an 8-hour course. It can be split over 2 days, 4 hours and 4 hours, or 1 day as an 8-hour course. After you complete it, you are certified in mental health first aid. We have really been stressing the importance of this in the schools for teachers, but also for parents, community organizations, churches. You know, I was speaking to the community college board yesterday, and I said 1 in 5 people have a mental illness. Every single one of us in this room has mental health. So it doesn't really matter what organization or school or group that you're working with. The training on, not necessarily this, any kind of training on recognizing warning signs and risk factors and how to connect people to resources is just, it's so important. House Bill 231 was passed in the 2023 legislative session. And I wanted to bring this up because it is around fentanyl and drug education. And I know this is a mental health task force, but you can't really look at mental health without also looking at overall behavioral health and substance use too. So this is a task force that was created, and we're partnering with the Mississippi Public Health Institute, and 2 curriculum have already been selected, Positive Action and Birdie Light. It's 2 fantastic curriculums. They're very supportive of any modifications that we want to make. It's going to be a pilot project. So we're going to start in 6 schools, and you'll see some more results of that. I'll go back to say for both of those trainings, mental health first aid and fentanyl and drug education, one of the reasons that it's so important to have our teachers trained in some type of mental health education is we know that 50% of all cases of mental illness begins before the age of 14. And we know that 75% of all cases of mental illness begins before the age of 25. The earlier you can detect, the earlier that you know warning signs and the earlier that you can connect someone to resources. That is what we want to see. Nationally, the average delay between the onset of a symptom to when a child gets intervention is 8 to 10 years. From the onset of their symptom until they get intervention is 8 to 10 years. So we've all got to do a better job. Shatter the silence. This is a suicide prevention effort that we have in our state. It's free for schools, well, for anyone. We have multiple different types of presentations, but it's about 45 minutes to 60 minutes, so it's not 8 hours. But it's a training on mental health, resources, warning signs of suicide, what to do, what not to do if you're talking to someone who's having thoughts of suicide, and it's offered at no cost to schools too. A lot of our schools across the state take advantage of this training. You can see that between our virtual presentations and the video training, there were more than 10,000 trained last year in Shatter the Silence. There's also an app that can be downloaded, and we encourage schools to do that as well. And you can see it was a little close to 3,000 times the app was downloaded in the last fiscal year. Connecting with resources is very important for families and for children. There's a lot of different resources that are available. We have a helpline, of course, at the Department of Mental Health. There's the local community mental health centers. Something that we're really excited about that we just launched is a Mental Health Mississippi app. So there's a website, mentalhealthms.com, and it has resources for individuals who have a loved one or who has a mental illness. It talks about crisis services. It talks about the civil commitment process. There's videos that walk you through the civil commitment process, but it's a website, and we know more and more people go to apps. So our team worked really hard to transition that website into an app. You can download the app and touch the number and get connected to your mobile crisis response team immediately. You can touch the number, get connected to 988. You can go to your county and click on your county and find the resources that are available in your county. And we're still building that out, and there'll be more things added to it. The other great thing about that is free assessments. It links to Mental Health America, and you can take a free assessment to see your mental health. And I'm just going to end with a quote, because I always end with a quote because I love quotes, and this is one of my favorite ones. Henry Ford, and it is coming together is a beginning, keeping together is progress, and working together is success. So you can see through all of the services that were described and all of the projects, they're being done by multiple partners, providers across the state. It's not in a silo, and that goes back to that working together, which that's what you're doing as a task force as well. And we're excited to see what the results that you come up with too for in October. So I'll be happy to answer any questions.
Well, I'm hoping we are going to have some good questions and discussion, about the information you brought forward. It's encouraging to hear some of the programs that you've described here. And then at the end, you kind of jumped into one of the questions I was going to have when you mentioned the Mental Health Mississippi app, trying to connect some of those resources together, because I see that as, if we have all of these separate programs out there, and, much like we did in workforce development, what we found when we started looking at that was that we had all of these workforce development projects going on all across the state, and they were all doing individually good things, but there was no communication between any of them. And so there was so much duplicity of action that really nothing was getting done. And so what we came out of that into is kind of a non-Republican idea of kind of putting a czar over that. And that's how the Office of Workforce Development actually developed, when we saw the need to kind of task that, or to kind of put a lead in charge of that, so that, we had a reporting kind of system that could analyze that. And so it sounds to me like you're moving towards doing that. I would assume, though, that something like that is a challenge for you to do. I mean, you have the things that you normally do, and then to add that onto the table is a challenge. So just after that discussion I just gave on it, what are your thoughts on any type of organizational change? Is that something to consider, not to consider, or is that already being done? You know, those are the kind of things I think we want to try to kind of flesh out of this committee, is what can we do to tie all this together?
There are a lot of partners and players at the table. So I think having regular discussions and things like this task force are very helpful. What you mentioned of kind of pulling all the pieces together, it is difficult. And if it's difficult for us in this arena to do that, imagine how difficult it is for the family member or the loved one who's trying to navigate the system to pull it all together and to figure out where all the resources are. So I think that's why, like you mentioned, having something where the resources are connected. Mental Health Mississippi is just a starting point to me. And that's just mental health. So there is, and I'm gonna answer a question you asked earlier too, evidence-based or best practices happening in other states. This isn't evidence-based or best practice, but this is something that's happening in other states that is having wonderful results. And I'm actually going to Washington on Saturday and we'll hear more about it, but it's called Network of Care. And it's a project that is on SAMHSA's, which is the Substance Abuse Mental Health Services Administration, for anyone who doesn't know that. SAMHSA's approved project list. You don't even have to ask if you can spend your federal dollars that way. You can. And it's a company, and they create a website for you, for your state. And it's not just mental health resources. It is, where do you go to get diapers for your child if you cannot afford them? Where are the food closets in your county? It pulls all of those components together. And there's probably about 15 to 20 states that have already implemented it, and it's fantastic. I've talked to those commissioners and they highly recommend it. The other part that it does is it can break down and do sites for regions. So they can do one for the department, or one for the Mississippi, the agency, the state, the entire state, and then they could do one for CommuniCare for Region 2. And they could have just the resources in your area. That's one way, I think, to bring a lot of people to the table, because if we're able to do this, you don't do it just by an agency doing it. You have to have players from across the state, because they're sharing their resources. And the site's only as good as who shares their resources. So you really want to have a good collaborative. To me, that's something that I'm really interested in, and I hope we can move forward with it. We're trying to get it approved through ITS right now.
And so you're
That
going,
in through the microphone.
yeah. So you're going Saturday, so that'll be something that you're working on a little bit
Yes.
while we're
So,
doing this.
yes, this weekend and next week is what's called the NASHBD Conference. It's the National Association of State Mental Health Directors. So it's where the commissioners from the states come together. And Network of Care was there last year. That was the first time I heard about them. And I got to see what they do, and then talk to states that have it. And it's good. You know? Okay.
I figured Senator Boyd was either going or she knew it was coming up, so that's my little sidebar question to her. But let's open it up more to the committee here. First, I'll defer to my co-chair here for the day for first questions.
Thank you. Thank you, Ms. Bailey. So the community mental health centers provide people to every school, public school.
They offer.
They offer. Do the public schools pay for this service?
No.
So why would they turn it down?
That's a good question. So
Maybe
you
that's a
have-
question for tomorrow with Dr.
Probably a question for the school too. But I will say, most of them accept the services. Some of them have accepted from a private provider. I think there's only, Linda, correct me if I'm wrong, maybe 2 or 3 schools that don't have either, according to the documentation that we have. So it may just be that they have a connection with a private provider in their area, and they would rather do that. Now, they pay for that service if they go with someone outside of a community mental health center.
Okay. And is that in every school or every school system?
Every school.
So every public school should have a mental health person in there. Okay.
Based therapist, yes.
All right. I know we're talking about children here, but when you get above 20, how would Medicaid expansion impact the services of mental health services?
anytime that people have access to care, it helps people receive the services that they need. For example, those slides that Dr. Gleason had that showed where Mississippi ranks in the nation, they're based off of 7 different categories. And one of those is access to insurance or just insurance coverage. You may have insurance, but your insurance may not cover the mental health treatment or the substance use treatment that you need. So to me, it's a bigger issue. It's a parity issue. It's seeing mental health and substance use as a health condition, just as you do any other physical health condition, and that it's covered by Medicaid, by private insurance, just like any other health condition. Parity to me is the big picture, but it improves access to care, absolutely.
Thank you.
Senator Boyd, I do want to say this. The people up here, senators and representatives, we're very good at asking questions and doing our thing, but we really want to hear questions out of the rest of the group too. And if you don't do this very often, it's all you can do is, you can sound silly like Senator Bryan does sometimes, but over a period of many years, sounding silly sometimes, you just go with the flow and just becomes natural for you. So I do want to encourage and say I've awakened him now. Yes,
I'll just point out at the very beginning, said what was causing all this trouble was all these internets. I don't do that like the rest of y'all do.
yeah, if we
That's
just
why
had
I'm-
one of
that's
them,
why
it
I've
wouldn't
been
be as
doing
bad.
better. I've been wondering what's wrong with the rest of you, and now I know.
I
Senator-
too have read that book about the internets. And I have a 12-year-old and it's scary.
Senator Boyd.
Kind of a technical question that I don't think you're going to have the answer for me right now, but just that, first of all, you mentioned there's 2 districts that do not have outside providers, and they also do not use their community mental health centers. Is that correct? Would y'all get me the name of those 2 school districts? I'd be very interested to know how they're meeting their obligations due to that. Second question too is, and this is a little bit technical in nature, but it's because of the new waiver from CMS and school-based health services. Could y'all find out from your community mental health centers, how many of them are actually billing for school-based services through Medicaid, and get that information back to us? So
We can work with Medicaid on that for Medicaid.
thank you very much.
And now would be that time where we can't be the same person every time. Dr. Johnson. Yes.
Hey, okay, go ahead. Joy wants to go too. Hey, thank you. So you started with your acute care and your residential treatment, and you're saying we're only servicing about 200 kids a year?
That's in the ones that the state operates. There's
Yes.
PRTFs across the state, not state operated.
Yeah, I'm just
Right.
kind of really focusing on what DMH can do.
Yes.
Do you know how many children and adolescent contacts DMH is making a year? Like actual patients?
In those 2 programs,
Mhm.
I don't know those numbers off the top of my head. I
Like
can tell you
assessments.
kind of.
What about across all of do you get across the whole network? Do you know how many kids are actually being able to access services through the Department of Mental Health, not the other
Not the
networks?
providers,
Right.
through the department. Those numbers that I gave you at the beginning. So Oak Circle Center, that is the child and adolescent unit, and then STF. Those are the only direct
For
state
inpatient.
operated.
What
That's
about
right.
and so community mental health, they're all private?
Those are,
providers?
they're actually part of the community. So they are
Okay.
part of county government. So they have a board of commissioners that's appointed by supervisor. So their oversight's the county.
Okay, so you guys
We s-
interact with them?
We certify
But they're
them.
independent providers?
That's right.
Do you know how many contacts, their children and adolescents in total? How many kids are we serving?
This is going to be, I think, FY '23 data. So I'm
Uh-huh.
going back almost a year and a half.
I'm good with that.
It was right at around 60. I think it was right at about 45,000 for children and about 65 to 80,000 were around there for adults. Now, that's the data that they report to our data warehouse. So that's if they specifically enter it into our system, but it was right at, I think, around 45,000.
Okay,
Mhm.
thank you.
Well, thank you for that. And I was just gonna say a couple follow-up things and wondering if you see it the same way. I really appreciate you bringing up both MAP teams and wraparound, and those both are in state law, thanks to Senator Bryan and Steve Holland. And one thing that wasn't on there about MAP teams is that's the single point of entry, and this is in state law, for children who need more, who have a significant mental health challenge and need the services of more than one system. So when they are entering the system or when they're returning from out-of-home care, that MAP team, which includes all those entities in the community, is supposed to be where that family can go to find that support. Now, that's a lot harder in reality than to describe it. And I appreciate what you said about the Hinds County MAP team. And we are trying very hard to bring all the partners together to really have that be that single point of entry. So that might be a pilot, but that's a real opportunity, I think, for this task force. And then the other thing that's in state law is wraparound care coordination. So one thing about both MAP teams and wraparound care coordination is that gives the family a choice of where they want their services from. So they can go to that MAP team and find out about all the services in their community and pick the ones they want. If they need ongoing care coordination and the child is that level of care, this isn't just for a child who needs counseling, they can pick their wraparound provider, and then that person help them find those services. So I think those are two things that are already in state law that are underutilized. And I think another thing that happened when those wraparound numbers went down, and I know this is a hard issue to work through, but Medicaid made a decision that about that time that we supported that changed the way wraparound and MyPac were billed. There were a lot of issues to work through, and I'm not sure they got worked through in the best way, but that's another opportunity this task force has to look at, because we've got all the players here. We've got providers, and I'm making you nervous, John, you can tell me. And, we've got Medicaid, we've got DMH. So there's a lot there that we already have to work with.
And you're right, MAP teams, it is in code, thanks to supportive senators and representatives several years ago. And it is before referring a child to a psychiatric residential treatment facility, before referring a child to a PRTF, which is that out-of-home placement, the community mental health center and must first have the local MAP team review the situation and ensure all available resources and service options have been utilized. And the purpose of that simply is you don't want a child to be removed from their home or their community unless there is no other option and you've looked at the resources and made sure.
And I believe the code says they are the single point of entry and reentry,
Yes.
but I could be wrong.
Go to Canopy.
Got lucky. First, I just want to say thank you to Dr. Gleason and Director Bailey for kind of laying out the topography of the landscape and where we are and where the gaps are. I just want to, I guess, Mr. Chairman, double click a little bit on something you had commented about there's a tendency from and Wendy, you mentioned this as a end user, how the various beads could feel disconnected and not strung together. And as Dr. Johnson noted, some of those beads are time limited by way of grant funding. And I think it'll be important for us to think about the standards that we want to require us as a state to have, below which the floor will not fall, and how we codify that. as an expectation for all kids. And then lastly, I just want to pick up on something, Wendy, you said about parity. Because a lot of, and today we're talking about public systems of care largely. They're private groups that are certified through mental health. But as I think about the public system, if you have a child with significant mental health challenge, you better pray they're on Medicaid. And so what we have to talk about though, when you think about the number of children that we have in the state, maybe up to 150,000 or so, of which a big portion of those are going to need care. A lot of those are in private insurance and they are in other healthcare systems, right? So how we think about the parity and the design, because children, for example, we talked a lot about PRTFs and STF, and those aren't accessible to children with private insurance. So I think we need to think about, as we move forward, as we understand the topography here today, how we have equal access to care for every kid in the state, not just those that might have state healthcare insurance. And I know and that's the beauty of this group, because we have a great kind of cross-section representation of public and private sector that I think is really going to be the solution long-term. So anyhow, I just wanted to note that as we're at the front of the journey. Thank you.
Very good. Got all kinds of questions in.
We do. So I guess my question is, if I wrote this down right, you said there's 519 school-based therapists in the schools. So is that 519 schools that total that are being served? Or are those therapists with the staffing shortage having to cover multiple schools?
Yes, you're
In
exactly
which-
right.
in
They're
which
many
case-
times having to cover multiple schools because of staffing shortages. Yes.
So in which case there is a barrier there and kids kind of falling through the gap there, as there's only a certain amount of hours in a day. And
Absolutely.
if they're going by the standards that they
Yes.
have to do 2 hours a day, 2 days a week,
Mhm.
you're losing kids there. So is there an ideal therapist to student ratio that, let's say in a perfect world, we had the staffing that we needed? What would that ratio be, or do you know that?
Well, and the 2 hours a day, 2 days per week is the day treatment model too. So that's kind of both. But the school-based therapists, there are 519. And I would say you easily need double that. I mean, to be honest, several years ago, I was involved in a task force on school safety. And one of the number one recommendations that came out of the school safety task force was more mental health therapists in the school. It wasn't necessarily, additional locks on the door. It was mental health therapists in the school. I would say that ideally, I would like every school to have at least one in their building all day long in a dedicated office with their dedicated space, that the parents have access to and that the students have access to. Because for those that can't get therapy outside the school because their private insurance won't pay for it, or let's say they aren't on Medicaid and the family can't afford it, or the parents work 2 jobs and can't take them after school or at night. There's so many different factors at play here. They need to have access to that mental health therapist while they're at school. Sorry, I get on soapbox.
Hey, excuse me, guys. This is Wendy Clemens with the Department of Education. I apologize for not being there this afternoon. I had a conference down on the coast, but I'll be there in the morning. But I was looking at the 519, Wendy. And we have about 825 public schools. And so if you think about, having been a former elementary principal, I depended on my region aid counselor. So we understand that there's only 519 and they're servicing all but 2 schools. They're probably pretty strapped, to help the professional school counselor with the mental health component. So I just wanted to share that.
That's an excellent point, Wendy. And just to break that down for you, so there's 519, 325 of those are community mental health centers, and 194 are private provider-based therapists. So it's a mixture of both, but that's where she's 800, a little over 800 schools.
Correct, about 825.
There you go. So you definitely, you need double the number that you have right now for really good coverage.
So I will I will follow up on that with, that is an area where the mental health component of telehealth, should it be able to continue on, would be able to fill that gap. If we're talking about overcoming barriers and filling gaps, then should the funding become available for the telehealth, mental health component, telehealth, great, all of it would be great if we could continue all of that, but at least if we didn't see the mental health component go away September 30th, then that's something that we continue on with, as opposed to creating an even bigger gap by losing that
I
resource.
think that's a good point. And in telehealth, especially in rural areas, it's a great thing to take advantage of. I will say I've talked to schools though, who sole telehealth is not always the best. If there's a crisis that occurs in that school, having a person physically there to talk to the students, it's needed. But there's absolutely a place for telehealth, and it can help, and it can help across the continuum of care.
Yes.
Do you think if mental health consultation in the schools was a billable service where they could do kind of like CHAMP does and go in and provide support to the teachers, not have a direct student they were providing one-on-one services to? Because I know that's can be helpful, but it's very labor intensive, and also it takes the child out of the learning environment. But if they could bill more for those consultation type models, do you think more could be done with the schools?
Probably so. I think that would probably be a better question maybe for the Department of Education for what they're seeing and what the schools need and want, but I think it would be worth exploring. Yeah.
Very good. Are there, yes.
Of the services being provided, do you know how often, when a child or an adolescent has a point of contact with the Department of Mental Health facility, whether it be an outpatient clinic, like a community, local mental health, or if it was something like the state hospital or STF, how often are they getting to see like a child psychiatrist?
A Department of Mental Health facility, we only have Oak Circle and STF. So it would be that right at about 300 a year. But again, that's the highest level of care as far as acute psych at Oak Circle Center, and then PRTF. So we don't have any outpatient. That's all by the community. Do you mean how many they're serving, or how many?
How frequently would a kid who was admitted to Oak Circle or STF see a child psychiatrist versus adult psychiatrist or a psychiatric nurse practitioner?
During their stay. So we have a child psychiatrist at both of our locations that they have access to. It would all depend upon the treatment team though, and what's recommended as to how many visits. They're also licensed under the Department of Health, and they have standards for psychiatric hospitals. So Mississippi State Hospital would meet those standards as well.
Are the local mental health centers, I know they're certified, they're not run by you, but they're certified. Are there any standards for them to have access to child and adolescent psychiatrists?
We have standards for our child services, but I'll tell you, there's such a shortage of child and adolescent psychiatrists that you had your slide up there. We've got 24 residents right now in Mississippi State Hospital's residency program, and thank goodness there's about 3 or 4 that want to go into the child psychiatry field, because we do not have enough in the state. Access to a child psychiatrist is very difficult to get.
I'm aware.
I'm sure all of you are.
Yes.
Hi, Wendy. I'm Heidi Nelson from USM. I wanted to ask a question about a statistic that you visited that exemplified something that's going well with 988 in Mississippi. I believe that you said we have the highest in-state answer rate with 90 staff. Is this an area where we are properly staffed?
No.
Okay.
No, we're increased. So we received, the Department of Mental Health received funding from the legislature and from the federal government that we are providing directly to those 988 call centers to where they can increase their staffing. They didn't have 90 a year ago. I mean, it's increasing.
Okay.
But so they are working to increase their staff as well. Because another component of 988 is chat and text, which is going to be much more popular with the group that you're discussing. And we did not have chat and text before. So that's something that's starting up and kind of coming off the ground. So they're definitely in need for some more trained counselors.
Okay.
at the
And
centers.
one more thing about the statistics related to 988 as it pertains to continuity of care or follow-up. You mentioned that 80% are receiving mental health and 63% are receiving social services. How are they gathering that data? Is it by follow-up text surveys?
Yes.
Okay.
So it's one thing that is being worked on with 988 right now is follow-up protocol. And questions to ask data together because it is anonymous for the first, call when you can give your name, of course, but it also is anonymous. It's not recorded. So that follow-up protocols being established, and then the partnership between 988 and the mobile crisis response teams. So our studies show nationally and in Mississippi that about 70 to 80% of the time, well, really about 80% of the time, when you call 988, the call can be resolved, the situation can be resolved over the phone with a trained counselor. But about 20% of the time, they're going to need to send out mobile crisis response. And that's where that comes into play, having strong protocols between that response as well. That's where I think I mentioned in the beginning, in this really this fall and the start of 2025, we're going to be having some intense training that's being paid for through a federal grant for mobile crisis response team, 988 call centers, and our crisis stabilization units, specifically on children and youth and responding to children and adolescents. So for the call centers and the mobile crisis for when it's connected.
And one more question as it pertains to duplication of resources. You mentioned network of care, and that certainly does sound promising. How is that different than the web applications and the websites that we see coming out of United Way for 211 services?
That's a good question. So they even connect. So network of care can connect and work with 211 for the resources. In several states that have strong 211, now not every state has strong 211, but in states that have strong 211, they are partnering together for that resource.
Okay. I'm not going to ask you if you think Mississippi has a strong 211 service. However, would you consider that in Mississippi that it would be duplicating resources, or do you feel there's?
I don't.
Okay.
I don't. I would love to know your opinion though. There's states, I can get you some states that have network of care and look at their sites and tell me what you think, because I don't see it as a duplication of service. When you go to these network of care sites for these states, you can click on intellectual and developmental disability services, mental health, substance use, primary care. You have a lot of different resources and it can intertwine and connect. So because it brings it all together, which I know that's of 211 as well, I don't think it's a duplication. I think the other good thing that comes from this, not just for the community to be able to access resources, is it brings together the people that have the resources to work together to build the site and to pull it all together, which I think is something that is needed.
Thank you very much.
I promise by the time this task force is done, we'll know everybody's names, but
Hi, I'm sorry. Okay, I have a question and then a follow-up question. So first, how are young people initially directed to mental health like services by the state, in the state? Is it typically through some mental health screening at the schools? Is it like a parent taking initiative on their behalf? Or is it like teachers reporting it? How does that typically occur?
I'm so sorry. I missed some of your question. Did you ask how is a student connected to care?
Yeah, I'm so sorry I wasn't speaking into
Oh,
the
that's
mic.
okay. So how is a child in Mississippi connected to care?
Typically, like what is the typical approach for a child to be connected to services? Is it through the schools with a teacher reporting it? Is there some sort of mental health screening process? Is it a parent taking initiative on their behalf as well?
It's a mixture of both. A lot of times it's a parent or a pediatrician in a visit. And then a lot though is with the schools. It's because, I mean, a child spends 8 to 9 hours of their day at school. So that's one of the reasons I think it's so important to make sure that our educators are aware to recognize those warning signs and risk factors and how to make that connection to care, because so much of it is noticed during that school day.
I definitely agree. So my follow-up question is, do you think it would be beneficial for there to be a uniform screening, mental health screening process across the state for all students to access? Because I just feel like a lot of mental health issues and illnesses go undetected or unnoticed, at least from my personal experience and my peers' experiences.
Yes, absolutely.
All right, thank you.
Well, I'll just follow that with, one suggestion that we've kind of floated around a little bit in our county, that, we have school resource officers that in most instances start in 9th grade. And what our sheriff has proposed is kind of doing a pilot program where a school resource officer begins at a younger grade, perhaps 4th grade. And the thought he has on it is that the school resource officer would not just have that group of kids in the 4th grade, but would move with the group. So the same school resource officer would be with the kids in the 4th grade, then would move with them to 5th, 6th, follow them up to, I guess, 8th grade, where they would normally just move on to the existing system. And the thought on that he has is that, in the identification of children who have problems and have issues, knowing a larger group of kids and have an association with them over a longer period of time, you can identify changes that might be coming up. Because I know teachers have a lot of burden put on them, and when they see a new child come in, at the beginning of the school year, who's acting a certain way, they may not know that this child the last year had been acting, a completely different way. But that's something I've been giving some thought to. Have you thought or considered any programs like that, or a different type of approach or similar approach in any studies you've done?
I think that's an excellent idea. That school safety task force several years ago, school resource officers were brought up as well. On a personal note, I'll just tell you, my son's school resource officer noticed when he got a new pair of glasses. He got out of the car one morning, and I mean, my son Brandon, he waves hello and goodbye, and he talks to that resource officer. I mean, it's a bud, because the teacher's more of their teaching, their enforcement. The resource officer, I mean, they high five each other. My son got out of the car and he said, "You got new glasses, didn't you, Brandon?" I'm thinking, my goodness, they build relationships. So I love that idea of them being able to move along. I would say, I think there needs to be a requirement that all school resource officers do have evidence-based mental health training, though, that they can recognize those warning signs. We offer it, we do, through mental health first aid and through the grant that we have, but all school resource officers do need mental health training.
So at very least, the 8-hour program that you
That would
mentioned
be my
in here would be a
recommendation.
good starting point.
Yes.
Yeah, and another thing too, on that particular point, is that the school resource officer in a lot of situations can be, a connection that can help with other problems, because if we have a younger child who learns that, the officer in the school at that point can be a help to them, that sometimes is the opposite of what they may learn in community or in other situations where, they may tend to want to maybe hide or, steer away from someone who can help them. Yeah, so that's something to, at least as we go through our discussions, to give some consideration to. But your point made me think of that. So that's what this is about, is, yes.
I love that idea. And one thing that we've done in our area is all of our school resource officers have to go through CIT. And that has changed everything. We've even had school resource officers who were off duty that ended up coming out into the community in the middle of the night because of that bond that they have with these kids. And so these officers that are in the CIT program really do learn how to just see these little bitty signs, and it helps with that assessment piece. So I think that, personally, I think all school resource officers should have to go through CIT because it has just been so beneficial in our area.
Right. Yes.
This question is about workforce shortages. Do you know any information about the percentages of qualified schools that are participants, schools or community mental health providers that are participants in the already funded National Health Service Corps loan repayment program, which would lend to attracting candidates?
I do not. I know about the program, but I don't know the percentages of how many are taking advantage of it.
Okay. What work is taking place within the schools, the community mental health centers, or DMH in order to gain momentum around increasing the number of locations or districts or regions that are certified for that?
I can't speak to what kind of work's being done around it. We had two representatives from HHS that came and shared some information with us. We've passed it, along. I don't know though the rate of how many are taking advantage of it, but it's something that we should be. I mean, it's something that we do need to be looking at. Loan repayment programs, scholarships, any way to help people choose this field, and to stay in this field and to stay in the state of Mississippi after they graduate and continue to work in the field in our state, we need to be looking at.
Listen, I'm a Louisiana girl, but now a proud Mississippian, and NHSC kept me in community mental health, and I stayed for 18 years.
I'll see if I can pull together and see how many are doing.
The follow-up I was going to have, I wasn't going to put you on the spot, but to that question, anything that you think that you would like to do, that you think we should be looking at in workforce development, I think this committee is very interested in. I know there's a lot of national programs, some with success, some not. And so please kind of supply us with that information in regards to that. The other thing I was going to ask you too is community health workers. We had legislation this past year that was brought up to look at community health, mental health workers. I know the state of Texas actually trained community mental health, community health workers specifically in mental health. And they're navigators. They weren't providing direct mental health services, but they are navigators, helping people locate and find mental health. Could you look at that program and look at see the efficacy of that? Because they are not as expensive as some of your mental health professionals, but your mental health professionals are having to do a great deal of that navigating. And so this gets them to more community available people who might be able to navigate that. And that was a real option that Texas saw, according to the presentation that I saw, was a good result. Could y'all look at that and give us some advice on that?
Absolutely.
Thank you.
Okay, I'll talk into the mic this time. Earlier you mentioned youth mental health first aid training for teachers, and I'm really happy to see my school district is one of the school districts offering those trainings. Theoretically, is there enough resources or trainings available for all teachers in the state to have this training, or could it be required of teachers because they do spend a lot of time with students and can pick up on these things and potentially get them the resources that they need?
We do need more trainers in the state. So there's train the trainer programs, and there's multiple entities, as I mentioned earlier, that are doing mental health first aid. It's not just the Department of Mental Health, but there do need to be more trainers. One thing that you could look at is that the schools, each individual school district train the trainer programs as well. Because if you waved a magic wand, gave the money for all mental health first aid and said tomorrow go train all the students, no, I mean, it couldn't be done immediately. Train all the teachers. You couldn't be done immediately. The other thing about that sometimes is a limiting factor here is you can't have a class of more than 25. There's role play that's involved. There's a book and there's role play that's involved. So you couldn't bring in all of your teachers in the Brandon School District in the auditorium and do mental health first aid for 8 hours because that's not even the purpose of it. It is interactive. So there needs to be more trainers, and I mean, we couldn't do it immediately.
Very good. Now I'll share this as one thing I always kind of share with other people is that if somebody goes and listens to a lot of other people talk quite a bit, always after any session like this, I like to try to mark down or come away with maybe 2 or 3 strong takeaway points that I kind of find in any discussion like this. So I would encourage each and every one of us to write those down, and then we can have kind of an ongoing list of the things that we felt individually were important with what we know, because we all come from different backgrounds that we think we could share as we're kind of trying to come up with ideas and then move this to the next stage, which is trying to come up with some solutions. So if you would do that, I think that would be a beneficial exercise for us. I want to thank, both Dr. Gleason and Wendy Bailey for the presentations to kind of help set the stage. As you all know, we have 3 speakers tomorrow. Will be sharing with us. For peer, one thing that I kind of found from this meeting today is the PowerPoint seemed to have a lot of information, and so the font size is very small. So if we could either, if there are PowerPoint presentations for tomorrow, if we could either have an emailed copy that's maybe sent to the members, at the time or ahead of the meeting, that would be helpful. Or if on the printouts, if the slides were a little bit larger, only if it's hard to see the information, I think it might be helpful for note taking. But with that, we'll talk more specifics tomorrow. But if there are no further questions, then I'll say we adjourn. I think we meet again tomorrow at 8 a.m. And so motion to adjourn. So see everyone at 8 a.m. tomorrow.